it's my proud privilege to be, in between all of you for the first webinar series on recent advances. The IPS Publication Committee, headed by our advisor Murugesh Vaishnav, and with able leadership and guidance from the entire IPS Executive Board. So the Publication Committee has decided to come up with a webinar series on recent advances, and we plan to release a book on recent advances in psychiatry in the upcoming ANSIPs. As a prelude to that, we thought we will have this series because recent advances is one of the little difficult and a dynamic topic for all postgraduates. And there is no one particular place to actually read on recent advances, and the topic keeps on changing. So what was once a recent advance topic may not be after a few years. So in connection with this book, we thought we will have this webinar series, and to start the series, we have a very eminent speaker, Dr. Adarsh T, and we have two eminent chairpersons to chair this session, Dr. Sujata Sethi from Rohtak and Dr. Vishal Indla from Vizag. We have Dr. Vinay Kumar, our incoming president, on this day to give some introductory remarks. So over to Dr. Vinay Kumar for your introductory remarks, sir.
I think Dr. Murugesh Vaishnav, our past president and your advisor, should speak first. Then I'll add something.
Sir, Murugesh Vaishnav, sir, over to you, sir.
Yes, good evening to everybody. At the outset, let me thank Dr. Vinay Kumar for actively working for the publication committee. And with the same energy and enthusiasm, Dr. Anil Kakunje has worked. And we have planned in all 4 books for this year, and first will be on the recent advances. To initiate this topic, we have started this webinar series as mentioned by Dr. Anil Kakunje. I welcome you all, wish you happy Diwali and happy New Year as per our Gujarati tradition. Thank you very much. And I wish all success to today's webinar, and we will have webinar once in a fortnight till the committee continue. And I success all the webinars. Thank you very much.
Thank you, sir. Vinay, sir.
Thank you very much, Anil. Actually,
I think the line got cut.
Still so.
Yes.
I got a message that you have been removed from the. So anyway, now I'm back. Friends, I remember taking over charge of publication committee in 2016 when we organized 1.5 day long, nearly 2 day long seminar for postgraduate students in Hyderabad. It was 60 miles away from Hyderabad in a resort where everybody was captive, including those who were speakers and teachers. And we had a program on research, publication, and presentation. And it was a big success. Nearly 200 postgraduate students attended the program, and everybody was examined after all sessions were over. And all organizers were thrilled with the fact that almost all participants scored more than 75% marks, which was conducted after the sessions. So that inspired us that probably there is a need of such book. And IPS Publication Committee thought about publishing a book on research, publication, and presentation. It's my pleasure to share that second edition of research, publication, and presentation is in the market, and it's a big hit. Another book for postgraduate education was published by IPS was Bedside Psychiatry. I'm happy to announce that we are going to have second edition soon. So our team has started working. It was the book was written by Professor A.N. Chaudhary, ICMR award winner and in UK. Now our chairperson, Dr. Anil Kakunje, is also assisting him in updating according to the needs of current times. So all our books are doing well. Meanwhile, it was rather called from student side, from different parts of country, that IPS must publish a book on recent advances in psychiatry. There was a call from publisher, our publishing partner also, regarding this. So the publication, I'm thankful to publication committee that they took the call, and the book is almost 70% chapters have been written already. And I take this opportunity to request Dr. Anil Kakunji and Dr. Mukesh Vaishnav to get all the chapters written by our colleagues peer reviewed. Because people might miss something. People might just ignore a few things that are not important. But if it is peer reviewed, I think then it will be a kind of perfect book. Because that book is the need of time. All our students need such book. Whenever I talk to postgraduate students, they say that recent advances, we try to find here and there, and we don't find proper everything in a book. So this book is for students, and IPS has always worked for postgraduate education, and now we are working in a more concerted manner, more focused manner, and this series is in line with our ambition and what we have decided to do for postgraduate education in our country. With these few words, I hand over to dynamic chairperson Anil Kakunje to take over and continue with the program. Anil, unmute yourself.
Thank you, sir. So without much delay, we will start the session. Initially, I'll introduce our chairpersons briefly. We have two eminent chairpersons. So first, ladies. So Dr. Sujata Sethi. Madam has done her post-graduation from the prestigious CIP Ranchi. For a brief time, she was working at CMC Vellore, and then moved on to Australia and was working as consultant psychiatrist at Victoria, Australia. After returning back from Australia, Madam joined the PGIMS Medical College at Rohtak, and she's been heading the department there and working as a professor and unit head for more than now 2 decades in the department with significant experience. She has authored 3 psychiatry books with prestigious publishers for undergraduate MBBS students as well as nursing students. And her areas of interest are child psychiatry and medical education, both tough topics. So very good to have you here, madam, and we are looking forward to your expertise and experience.
Thank you. Thank you.
Welcome.
Thank you.
Next, we have Dr. Vishal Indla. I'm really happy to have the privilege to introduce Dr. Vishal, who was one of my contemporaries during my Niman's days. Vishal won the Best Outgoing Student Award for MD Psychiatry in 2005. He received the World Psychiatric Association Young Psychiatrist Fellowship in 2007 at Melbourne, Australia. Currently, the Chief Psychiatrist at Indla's Women's Hospital, Vijayawada, and which also the hospital runs DNB Training Center and Doctoral Fellowship in Child and Adult Psychiatry. He manages chain of exclusive child psychiatry clinics across India at Vijayawada, Vizag, Mumbai, and so on. And he is the South Zone IPS representative to the National Executive Council. So it's our pleasure to have you, Dr. Vishal. And I hand over the session to the chairpersons to introduce the speaker and then over to Adarsh T. Over to you.
Okay. Thank you, Dr. Anil, for nice words. And it's my pleasure to introduce Dr. Adarsh T, who is Professor of Psychiatry at King George Medical University, Lucknow. He has more than 120 international and national publications, 15 book chapters, and what to talk of the books that he has to his credit. He has participated in many research projects funded by NIMH USA, John Hopkins Medicine, and ICMR, just to name few. He's a direct council member of Indian Psychiatric Society and honorary deputy editor of Indian Journal of Psychiatry, honorary general secretary of IPS UP State Branch, and also he's the editor of Indian Journal of Behavioral Sciences, that is for Central Zone. If this was not enough on his shoulders, he co-chairs early career psychiatric section of World Association of Social Psychiatry. His areas of interest are again very interesting, that cognition and cognitive neurosciences, cognitive behavior therapy, human sexuality, and spirituality. No doubt he has bagged several awards and recognitions. We are privileged to have him as the speaker today. We welcome Dr. Adarsh for this session, and over to Dr. Vishal. Thank you.
Thank you, Dr. Sujata. Let me just set the context for today's talk by Dr. Adarsh. We know that there are a lot of recent advances happening right from psychopharmacology, where you have ketamine, a lot of newer antipsychotics, a lot more in the pipeline. Even for dementia, there's a recent newer drug which is filled with controversies. There are a lot of recent advances in policies itself, the laws that we have to follow in our country. There are also a lot of advances in neuromodulation. Neuromodulation, some people say, is going to be the future of psychiatry. Deep RTMS, TDCS, deep brain stimulation. So there are a lot of exciting things that are happening, not to mention the developments in biowearables. How biowearables can track compliance, for example, can track somebody's sleep patterns, circadian rhythms, and how they can help the patient and the doctor make better choices about medication. The introduction of artificial intelligence, how it can change the face of how we practice psychiatry. Virtual reality, for example, how that can be used in therapies. We are already using a virtual reality technology in our hospital itself. So, and of course, psychedelics, the renewed interest in psychedelics and how they can transform treatment in certain psychiatric conditions. There are a whole lot of exciting things that are happening, which are of interest, not only to practicing clinicians like us, but also to postgraduates, because they have an exam to pass. So we have a prolific academician in Dr. Adarsh in the midst of us to talk about these things and take us through this introductory talk and set the stage for further talks in this area. He's a wonderful speaker and a very good friend. Dr. Adarsh, over to you.
Thank you very much, Dr. Vishal, for these kind words. First, at the outset, I would thank Dr. Vinay Kumar sir for asking and inviting me to give this talk. Also to IPS office bearers for holding these series of conferences, webinars in recent advances. I'm happy to have two learned co-chairpersons. So if I falter somewhere, I hope that they'll be able to handle the things. As Dr. Vishal just pointed out that this recent advances is a very dynamic topic and it keeps on changing. And I was finding that his list of his selection of topics was quite similar to what I thought first when I got this topic assigned to me. Let me confess that once when I was asked to do a presentation on this, I had quite a lot of time to gather my thoughts that what I am going to speak in recent advances in psychiatry in 40 minutes, because that is something very challenging task, that you have to consolidate your ideas in 40 minutes for whole of the psychiatry. So obviously you might see that there might be certain omissions. Some of my selections you might like, and some of my selections might surprise you. Many of the people might listen few new words and few new concepts that might be coming, and for senior people or Other people, it might be just a slight revision for the concept they have heard here and there. So once I started gathering that what I'm going to speak, I made a list that what I'm likely to touch upon. So I'm showing this slide. Usually what happens when you make a presentation, you sort of make the presentation and in the last put the sequence of what you are going to speak in this presentation. But for this presentation, I made this list first, then sort of tried to condense it, cut it, and see that what I can fit in these 40 minutes. So what I thought are likely importance for this talk are some historical prospect. Although we are talking about recent advances, but without looking or without contextualizing what you are going to talk, without looking historical context, you are not able to relate that what is happening right now and what is going to happen in very recent future. Then obviously most important and most exciting part of discoveries and recent advances in psychiatry are happening in the field of biological domains, that advances in neuroimaging, genetics, neurochemistry, molecular basis. So these are also forming an important part of this next talk. Certain aspects related to nosology. Then there are a lot of practical changes happening in therapeutics, the way we deal patients in terms of pharmacotherapy, brain stimulation, as well as psychological interventions, which we offer to our clients. In backing and in promoting all these research method and statistics, we cannot undermine the growth that is happening in research methods and statistics, which are helping us to bring better science and giving us fruit of so that we can utilize these in our improving our understanding as well as improving our treatment capacity of the patient. The technology is influencing all the domains of our life as well as the medical discipline which we are practicing. So information technology, virtual reality, machine learning, big data, these are some of the things which we might come across in this presentation. But let me tell you, I could not have covered all these topics in these 40 minutes. So I have selected few of the important topics. So these will not come in the sequence they are shown in the slide. They will come consolidated here and there, but I will try to touch upon most of these things which I have mentioned in this slide. So if I had to write the keywords for this presentation, as we write keywords for paper which we have to publish, so the keywords would have been genetics, neuroscience, and technology. But we need not to think only in the context of what is happening globally in general, psychiatry as a science, but we need also to think what is happening locally in India. So the laws, policy, and program that are happening right now in India are also very important to understand, and they actually influences the way we practices on day-to-day basis, and very important for understanding what is recent developments in psychiatry. So I will start this talk with a quote by Edward Deming that he said that in God we trust. All others must bring data. So this summarizes the developments in science, that science must be backed with data. Unless you do not have data, the hypothesis driven theories cannot take you long. So with this change in scientific technology and understanding, a lot of things started happening. And with this concept, a lot of epidemiological work has been done in last few years. And this data actually put lot many things which has became important in psychiatry. In last 2-3 decades, you know that the importance of psychiatry becoming more glaring for policymakers because of presence of data. Earlier, when health statistics was discussed in terms of mortality, obviously psychiatry would not be incorporated in list of important illnesses. But once the concept of this disability, daily disability adjusted life years, year lived with disability, when these concepts start coming in medical sciences, and we started seeing non-communicable disorders causing a lot of disability in the world, then this data started showing that mental illnesses are actually one of the most disabling disorders of the world. So this global burden of disease data in 2019 says that mental disorders are among top 10 disorders causing disability in the world. So once you have the strong data on your side, even the most strong critic has to keep their mouth shut, because we know that psychiatry has passed through a very turbulent history, and a lot of critic and a lot of saying that this is not true science, and lot of critics. So if you have strong data on your back, you should you can show to policymakers and get a lot of things that we need to have as a progression of science. This data also came in terms of India, and in India also the mental disorders are, although relatively lesser in importance in comparison to world data, but they also comes in top 10 disorders causing mental disability. There are a few very good studies in understanding the impact of mental illnesses as disability in India. So I would definitely recommend residents to go through these studies, specifically this global burden of disease study, which has studied the data from 1990 to 2017. To summarize the most important finding of this data, that 1 in 7 people in India, like roughly 14%, have one or other mental illness. Contribution of mental disorders of disease burden has almost doubled from 1990 to 2017, and percentage of daily due to each cause like depression, anxiety disorder, developmental disability, schizophrenia, bipolar disorder, conduct disorder. These are one of the significant illnesses that we need to take care of, and that decides the way funding is allocated, policies are developed, and health planning is done in the country. We almost everybody, I hope, is aware about the National Mental Health Survey. Just to emphasize that this was one of the largest representative sample of 34,000 people conducted across 12 states. It shows statistics similar in line of global burden of disease, that almost lifetime prevalence was 13.7%. But important differences are also identified, that urban metros, the prevalence of schizophrenia and other psychotic disorders were higher in comparison to rural areas. It was roughly 2 to 3 times. Severe mental disorders, mood disorders, and neurotic disorders were 2 to 3 times more in urban metros in comparison to rural parts of India. So these differences are also help us in understanding that the differences of overall statistics which are there in comparison to Western worlds, saying America, UK, or European countries in comparison to India. So I hope that what is happening, if we extrapolate these kind of data, the way the economy grows, and we start sort of developing more economically, the mental disorders grows. That there are a lot of theories that why this is happening, but this is what data says. Also, there is high number of substance use in India. Tobacco use disorders to the tune of 20% and 4.6% of alcohol use. Percent of mental disorders is also very high in children and adolescents, and as well as very important data saying about there is very high treatment gap. Up to 60% of patients who are in need of treatment are not able to receive sufficient medical treatment. That is a very glaring statistics, and that's definitely needs attention urgently. Then once we understand that what is the true prevalence of mental disorders, and these studies bring the importance of mental health to the forefront for policymakers and those who develop programs, understanding that how to categorize and how to classify disorders are very important. We know that there are two most important systems of classification in psychiatry, DSM-5 and ICD. ICD is the most important system that are used by most of the countries. So I'm just showing you a glimpse of the changes that are happening in terms of ICD-11. I hope that everybody should know that ICD-11 has to start implementation from this January 2022. So it is already notified and it is up to countries to take up using this. So what is happening that these classificatory systems are developed for having greater global applicability, having good scientific validity and clinical utility. Here in ICD-11, it is being tried to keep it in greater harmonization with DSM-5 because it causes a lot of research dichotomy otherwise if these two classificatory systems are not in greater harmony. So these attempts had been made. There are entry of several new disorders in ICD-11, that bipolar type 2, which was not present earlier in ICD-10 or earlier versions, has been introduced. Other disorders like olfactory reference syndrome, hoarding disorder, complex PTSD, prolonged grief reaction, body integrity dysphoria, gaming disorder, compulsive sexual behavior disorder. These are some of the new disorders that are being introduced into the ICD-11 category. Few disorders are renamed or inclusive naming has been used, like previously we used to call mental retardation, now we are calling it intellectual disability, keeping the latest development in disability fields. Similarly, the name of dementia and organic disorders has been changed to neurocognitive disorder and neurodevelopmental disorder for childhood developmental disorders, in keeping with the latest scientific developments. So there is reason for all these changes, which is backed by science. Because of shortage of time, I will not be able to tell the reasons for each one of them, but for students, it is important to know that this is happening, and they need to have a good idea that why this is happening. Some disorders are reorganized, like anxiety disorders used to have OCD and related disorders earlier in the same group, but now this has been separated out from anxiety disorders. There is a refinement of diagnostic criteria for several existing diagnostic categories, for example, catatonia. And one of the important changes are that sleep-wake disorders and conditions related to sexual dysfunctions were separated from mental health section. So this change has primarily been made by understanding that in the science that sleep-wake disorders and sexuality are multidisciplinary disorders, and keeping in a separate section would help in greater facilitation of integration of multiple disciplines, so that multidisciplinary research can be improved and more useful data can be generated in this regard. However, we know that current nosological structures are not very satisfactory. They do not truly reflect the scientific developments which are happening, and they do not truly reflect the disease conditions which they are categorizing. For example, we know that schizophrenia is not a disease, homogeneous disorder, as we know. Now we know that it is hundreds of diseases that are clubbed in schizophrenia. Same for depression or several other disorders. But the latest development in science has not reached to the state that we are able to separate out it and use it specifically in classificatory systems. Some of the alternative approaches for nosology is like research domain criteria of NIMH, RDoC, which we call in short. So it is sort of the biologically informed framework for understanding mental disorders. It is currently used for research purposes, and we hope that when the research ingrained categories are used more in research, so it will likely to bring more useful data, which is likely to inform clinical practice also. In the same way, strategy of reverse nosology, which suggests that we should redefine diagnostic criteria based on their molecular, cellular and circuit basis, rather than what we are currently doing, that we are defining our diagnostic categories based on symptoms and person's subjective experiences. In the same way, there are suggestions like we should categorize these disorders in type of biotype. Biotype are the subgroups of diagnosis which are more conveniently divided on the basis of biological characteristics rather than only symptoms. And there is another approach of hierarchical taxonomy of psychopathology, HITOP in short, which is sort of dimensional approach of diagnosis and taking hierarchical importance of subjective experiences by person. However, these are some of the contemporary alternative approaches and currently not suited for clinical use. This is what I am talking about, that this is the reverse nosological approach, which is considered that if we are able to use at least some of the concept of these nosological status, that incorporating information which are gathering about genetic structure, molecular structure, cellular dysfunctions and circuit level dysfunctions in the diagnostic category, it will likely to improve the research output as well as therapeutics. However, the information is immature and incomplete as of now to incorporate these in clinical practice. Now, the another frontier where a lot of changes are happening in psychiatry are genetics. There is so much of the information in terms of genetics of psychiatric disorder that it is impossible to collect in a small presentation. But I will try to inform about the most important trends what are happening in genetics of psychiatric disorder. Now we know that heritability estimates of psychiatric disorder by twin studies are generally between 80% to 40% for most of the psychiatric disorder. Highest heritability has been reported for disorders like autism, bipolar disorders, to lowest heritability for disorders like anxiety disorders and depression. The genes, which are the candidate genes, which we call them, which has been identified for several important psychiatric disorders like genes for schizophrenia, bipolar disorder, depression, autism, are not very specific for them. Like the person who is having candidate gene for schizophrenia, the similar gene might be there in patient having bipolar disorder, depression, autism, ADHD. So there is a lot of crisscross between these disorders which are having dysfunctional genetic system at the base level. So these disorders are actually, there is a lot of discordance between phenotype and genotype of these disorders. And there is another important information that is coming up from the genetic studies, that this risk of having higher rate of mental disorders is not exclusive to mental disorder, but this additional risk also extends to several non-communicable medical disorders like cardiometabolic traits, such as having higher BMI, type 2 diabetes, and coronary heart disease. So we need to understand that people who are having higher rates of cardiometabolic disorders, diabetes, coronary heart disease are not solely due to lifestyle risk factors or medications which we use to treat them. There is also inherent genetic risk of having more of these problems with these disorders. There are certain terms which we need to understand. I will not be able to go in detail, but I will just tell them so that medical students can go there and read there, maybe in the book which is being released by IPS. Like there are genome-wide association studies which try to study whole genome of the patients and try to see that what are the important candidate genes that can be implicated in those disorders. But for conducting sufficiently successful genome-wide studies, we need to have a very large group of samples, which are not usually possible to have by one center or one group of researchers. That is why psychiatric genomic consortiums has started in the world, which is group of researchers across globe for conducting genetic research in a disorder. Like we are also part of one psychiatric genomic consortium on bipolar disorder, conducting genetic research on these disorders globally. So these consortium try to have a patient sample of 50,000 to 1 lakh patient, which is a very large number and not possible for any one group of researcher. Then there are certain terms like copy number variants. It is simply the variation in number of nucleotide that are present normally. It is likely to enhance the risk or reduce the risk of particular disorder. Single nucleotide polymorphism, that polymorphism happening at level of only one letter of a nucleotide. So these are important concepts, and they are influencing the disease risk, where the whole gene is not dysfunctional, but only one small variation, that having more of that gene or less of that gene, or variation at only one letter of nucleotide is likely to alter the risk of that disease. So these are important concept in genetics of psychiatry as of now. Then there is something like polygenic risk score, which estimates the cumulative effect of common variants associated with the trait at the individual level, hence risk of disease development. So these polygenic risk scores are now being given to the people based on genome-wide studies of even the people who are at risk, so that we can tell that how much risk this person is having for development of this disorder. However, the data or science has not been developed at this stage that we are able to use it in public or clinical context as of now. These polygenic risk scores may also be useful to stratify patients in terms of prognosis or response to treatment. So to explain this concept in terms of metaphor, that for our PG students, we can say that if each person has born with a certain risk, certain genetic risk of each disorder, like they having certain amount of water in their glass. Now to develop the disease, they need to reach a certain threshold. So this base amount of water for each person is different. So they are born with certain risk of several mental disorders. So each one of us is born with some risk of having some or other psychiatric illness. This is obviously different from person to person. If this is combined with environmental risk factor and it reaches to a certain threshold, that person is likely to develop that disorder. So that is how, if person is having higher genetic risk and few environmental factor, they might manifest disease early, more severe disease, or person who having less risk, having multiple environmental factor, are likely to develop lesser serious illness later in age. Those sort of variations might happen due to interaction of genome and environmental factor. To give some more detailed view of one disorder, like for example, we are talking about schizophrenia. As we discussed, it is highly polygenic. As of now, today, as we are speaking, up to 340 susceptibility genes has been identified for schizophrenia. More than 100 biotypes has been identified. As I told earlier, that biotypes are the biological subtypes of that disorder. So it is some characteristic which are happening at cellular level, receptor level, or molecular level. So if those characteristics are prominent, we call this as a biotype, and they might have any type of symptomatic manifestation, which may also vary according to other risk factors. There are copy number variant related abnormalities, de novo nonsense mutations, which are related to enhance or alter the risk of having schizophrenia. So in short, schizophrenia is not only very complex, but also extremely heterogeneous brain syndrome. As we see clinically that no two patients of schizophrenia are alike. So this is what is happening at the level of genetics also, that there is a lot of heterogeneity at the genetic level. That is why we are not able to have any lab test or biomarker for schizophrenia, despite so much of research in genetics of schizophrenia. there are very few practical uses of developments of genetics in schizophrenia as of now in the world. One of these practical developments is related to pharmacogenetics. There are clinical pharmacogenetics implementation consortium, Dutch pharmacogenetics working group that are trying to sort of develop practically useful guidelines for clinicians. Most of the pharmacogenetic use which is happening in the world right now is related to coating of cytochrome P450 enzymes, identifying different variants. So if we are able to identify different variants, we can see that what is the dose adjustment needed for this particular person, and can recommend that this medication is better for this person or we need to avoid this medication. Available evidences suggest that those who do not respond or tolerate at least one previous antidepressant or antipsychotic are more likely to benefit from testing, because as of now, these testings are very costly and cannot be recommended to use in every patient which drops at our clinic. So if person is not able to tolerate the first treatment, then these sort of strategies are available in some part of world, and these are being used in clinically in practice. However, the translation has not been relatively very easy or smooth. I remember that when I attended 2017 Berlin World Psychiatric Association conference, there was a lot of enthusiasm related to pharmacogenetics in that conference, and a lot of presentations were made that said that this is just around the corner, and in a couple of years, everybody in the world will be using pharmacogenetics to better identify what kind of medications the person is likely to benefit. But the 5 years, half a decade has passed, and we are not seeing anything that happening. So the promises somehow are higher than what that can happen actually. Currently, only few primarily research institutions are using this strategy. However, this do have certain utility. Similarly, for carbamazepine and oxcarbazepine, people having HLA-A or HLA-B certain subtypes, they are likely to have more risk of developing severe cutaneous adverse reactions. So if we have these kind of information available to us, obviously we'll be able to better inform that what kind of medication this person is likely to respond better and what kind of medications we need to avoid. There is several other related developments in genome, like Human Genome Project, which many of you might be aware that has been completed in 2003 or 5, where we have mapped whole of human genome. Human Epigenome Project, Human Connectome Project. The image you are seeing on left side of this slide is from Human Connectome Project, which is identifying all the connections of neurons in the human brain. So these sort of developments are happening, and they're likely to impact our neurosciences significantly in the time to come. There is also very high excitement regarding a new technology which we call CRISPR. It is a very specific technology of gene editing. I will just name this technology and not be able to tell much detail about this, but it is very specific technology of gene editing and it can very specifically target certain amount of genetic material from any cell. And a lot of enthusiasm and excitement related to its use in medicine and psychiatry that is happening. So people should know at least what is this technology. As the growth of genomics is happening, we see that it is not only genomics that can influence biological science, but related developments which we as a group now are calling omic sciences. Sorry. So what are these omic sciences? Like study of DNA material is called genomics. So transcriptomics is gene expression patterns, that how these genes are expressing in humans. That is also very important aspect of genetics. Then comes proteomics, that is dynamic protein products and their interaction as happening in health as well as disease. And metabolomics, is also an intermediate steps in understanding organism's entire metabolism and how this is being influenced by earlier omics. So all this information is likely to be needed if we have to see the real impact of genomics happening on clinical practice. That is what is people's aim as of now. So we need to understand and know these concepts as of now. Another important development which I like to talk about in this talk is development of evidence-based medicine in general medicine as well as in psychiatry. It is not very old phenomena, so we need to understand that only in last few decades we started understanding importance of evidence-based medicine. People in up to late 20th century were having hypothesis-driven concepts related to psychiatry and psychotic disorders. But with this evidence-based medicine, we now know that there is series of scientific evidences that has importance in making clinically important decision for patient. And randomized clinical trials, then systemic reviews, these are sort of information that we need to have for having good quality of evidence that can be used clinically, and policy and programs need to be informed by that. This growth of evidence-based psychiatry has been also very important, that if we think historically, it is in DSM-3R when first time a theoretical approach to classification has been taken in nosology, like the Freudian or other hypothesis-driven system was left aside, and whatever research evidences were available, the classification was made according to those systems. So with accumulation of these RCT data, systemic review data, we started developing clinical practice guidelines, and now we see that these are one of the important aspects of standardizing the way we treat our patient. That so there are certain standards of treating our patient, and evidence-based medicine is playing very important role in these strategies. A lot of time there are a lot of critics of evidence-based medicine. So people try to do independent clinical trials that are not financially supported by a pharmaceutical industry, as people say that this matter of financial support is one of the key factor for influence that might be happening at the research level. So the students must know about these CATI, CATLAS and BALANCE trial. I'll not be able to tell about detail about these trials, but a student must know that what are these independently conducted clinical trials, as well as certain resources which are there right now available, like Cochrane Library, which is collection of high quality independent evidences to inform healthcare decision making. And this is one of the important source of mental health information also. As we talked about clinical practice guidelines, so these are one of the important aspects of standardizing practice of what is happening in the field. Like we have a whole range of clinical practice guidelines developed by different associations like APA, NICE, CANMAT, MOTSLE, our own Indian Psychiatric Society guidelines, and subspecialty association guidelines like bipolar disorder associations, child psychiatry, geriatric psychiatry. So these are important aspects of evidence-based medicine. Then the large data which we are accumulating is used for in variety of novel ways, like this one example of network meta-analysis. So this sort of statistics tell that what are the grading of efficacy as of now. As we know that amitriptyline is considered one of the gold standard in efficacy, so this research shows the same. But if we think in terms of acceptability, a drug like agomelatine tops the list. So research clinicians might see that where they can have a good combination of efficacy and safety. So these sort of network meta-analysis are available for almost a lot of conditions like antidepressant, antipsychotic, augmentation, child psychiatric disorder. So these sort of data are actually influencing the clinical practice. and useful. This is the graph from the same study showing that if we think in terms of to see that if we see that what is the acceptability and tolerability profile. So number 2 is amitriptyline, number 21 is vortioxetine. So this sort of try to give you a glimpse of whole data so that clinicians are able to make better and clinically informed decision in terms of evidence-based medicine. Psychopharmacology is one of the most important area touched by these advances. We know that psychopharmacology, the most important basic premises has been efficacy, safety. Although therapeutic targets over the whole historical periods remains the same, that chlorpromazine and haloperidol acts almost on the same targets as our recent medications, but there have been a lot of changes in our understanding and the way we are developing and using the medications now, and classifications are being promoted to be on mechanism of action rather than dividing medications as antipsychotic, antidepressant, anti-anxiety. For an example, because we'll not be talk about all the medications, I just choose an example of atypical antipsychotic to see that how this evolution in psychiatry has happened. For example, clozapine has been discovered in 1972. These are called first generation SDAs. We are not talking about first generation antipsychotic and second generation antipsychotic. In in SDAs, sometimes people try to classify that clozapine, who has been developed very early, to the whole range of medications that has been developed. And now we have certain medications like aripiprazole, brexpiprazole, or cariprazine, which we now try to say that these are slightly different. So we can call them third generation antipsychotic. And some of the latest medications like pimavanserin and lumateperone, I'm also currently involved in conducting a clinical trial for this lumateperone in bipolar depression. So these are the latest changes that are happening currently. The concept changed, these new medications have lesser EPS, less risk of hyperprolactinemia, reduced anticholinergic side effect, histaminergic and other side effect, and they at least claim to have better negative and cognitive symptom and better quality of life. But some of these medications obviously have higher risk of metabolic side effect, and people say that at least there have been no significant improvement in overall efficacy, or even some of the medications have reduced efficacy. But we tend to see that we now try to see that which are the treatment options that does not only reduce symptom but can give best quality of life to the person. So it is not only efficacy that is the important aspect of treatment, but improving quality of life and reducing disability is one of the important aspects. So a lot of this second and third generation antipsychotics are very similar in their efficacy if we try on a group level, but they have slight differences. So we select them on the basis of what is best for one particular client. And if you think in terms of antipsychotic, then we know that these medications were primarily used for psychotic disorders and manic episode. But now a whole range of new indications has been developed for these disorders, ranging from primary use as mood stabilizers to augmenting agent in various psychiatric disorder, treatment resistant conditions, to behavioral disturbances in dementia, childhood psychiatric disorder, use in delirium, non-specific use in agitation and aggression. Dr. Vishal very early mentioned about use of ketamine, esketamine. So these are some of the new treatment strategies which are happening in depression. There are a lot of new antidepressant has been developed similarly to what we talked about antipsychotic, and the certain new treatment strategies like esketamine or ketamine is considered entirely new way the antidepressants are working. So these are some of the exciting discoveries happening in psychopharmacology. Then impact of technological growth. I know, chairpersons, that I am exceeding time limit, but I hope that you'll be able to give me a few more minutes for completion. Then there are a lot of technological growth that is impacting the way psychiatry is practiced right now. This technological growth is enabling us in developing digital phenotyping rather than only symptom-based phenotyping, digital phenotyping that can help us in improving diagnosis and treatment. So there are developments in digital therapy, computational psychiatry, use of virtual reality that has actually started happening in clinical practice, artificial intelligence and machine learning that is picking up very high. And there is whole range of new mental health apps that are, some of them are actually useful also. A lot of them are actually very useless and sort of not to be recommended, but many of the mental health apps are useful, and we soon expect that in near future we may be recommending psychopharmacology along with some mental health app, that you use mental health app along with this medication to improve your chances of success. That is happening in some of the conditions, like the trial are going on drug use and several other conditions. In similar technological development, aripiprazole has been used as a first digital pill. So what is happening, that if the person will take this digital pill, it will go dissolve in stomach, and a sensor will release that will send the information to app that the medication has been taken. And this information, if patient permit, can go to clinician also. So the clinician can track a record that the compliance is being maintained. So these sort of technological strategies are being developed to see what kind of things might happen in psychopharmacology and technology. We might see that these might not be very useful, but we need to think in terms that in what many ways that technology can be incorporated in psychopharmacology, and there may be certain cases where this sort of strategy might be very useful in a certain group of patients. Then brain stimulation is another important area, and two current strategies like TDCS and RTMS are very promising. We are experimenting with novel stimulation parameters, like Dr. Vishal mentioned about deep RTMS, theta burst stimulation, multiple sessions over a single day, using two different areas simultaneously. So there are a lot of stimulation parameters, novel treatment administrations, novel targeting, addition of neuro navigation techniques, or robots delivering brain stimulation to save the time and improving the efficacy of delivery. So all these sort of technological assisted and science assisted interventions are happening right now. And there is a whole lot of newer neuromodulation strategies. Some of these are in the textbook for quite some time, like vagus nerve stimulation and deep brain stimulations. But some of these are certain new, like transcranial alternating current stimulation, low intensity focus ultrasound pulsations, combining neuromodulation strategies with behavioral and psychological intervention. A lot of trials are going on in this field. And optogenetics. Currently, it is a research method, but it uses light as a source of neurostimulation, and it is said to be having high promise if that can be used therapeutically. Then this innovation in this brain stimulation devices is also likely to happen as advances are growing in nanotechnology, molecular biology, neuroengineering, material sciences. So all these areas all already started impacting brain stimulation devices. I'm not having time to elaborate on this thing. I'm just pointing out that there is a lot of rapid advances happening here. And in terms of neuroprosthetics, having additional neurological senses, compensating cognitive loss that has happened due to some disorders, or brain machine interface that can enhance the already existing capacity. So they are also likely to be used in treatment of some of the mental disorders in near future. Then there is growth of certain newer frontiers. I took one example of gut microbiome interface. There is a lot of information about this interface, like we can understand importance of this gut microbiome interface, that this is called the second brain inside the human body. It is also called newly discovered organ, and very important aspect, as we know that this gut microbiome influences significant way the brain develops, functions, and the structure development happens. And also it influences the health and disease. And it is started finding its utility in several medical as well as mental health disorders. And a lot of research is going on, and it is likely to impact the our clinical practice in very near future. Then understanding the recent legal development are one of the important aspects. I will only be able to touch upon the names, that what is happening. One need to understand that what is United Nations Conventions for Right of Persons with Disability and how it is impacting development of mental health laws all over the world. Then understanding Mental Health Care Act, what is the basic philosophy of this act and what are the challenges and utility of this act in current context of India. Then legal developments in context of LGBTQ population, that recognition of transgender that has happened in India, decriminalization, repeal of section 377, removal and upgradation of medical textbooks for queerophobic information as per order of Madras High Court, that is happening. That has just happened last year, and it is likely to come over in the newer textbooks of medicine. Then POXO Act, National Mental Health Policy, National and District Mental Health Program. What is happening in these terms are very important aspect. These are my last few slides. As what has happened that I might have shown a lot of information that shows that only developments are happening in biological sciences. This does not show that only it is importance of biological psychiatry. So this biopsychosocial model is still important, and I will recommend medical students to read this article. That is, it sort of summarizes that what is the current validity of biopsychosocial model in contemporary psychiatry, published in Indian Journal of Psychological Medicine. And to summarize that, a lot of advances are happening in psychotherapy also, like biological basis for psychotherapy has been identified, that these talking therapies are also actually influencing brain's structure, functioning, and neurogenesis. So this talk therapy is not only behavioral intervention, it is causing actual changes at the brain level if it is conducted effectively. Evidence-based of psychotherapies has recently improved, and only in earlier where it was only hypothesis driven, a lot of importance is given to having good evidence base. That newer approaches like having cognitive behavior therapy, all know that having metacognitive therapy on that, adding mindfulness strategies, and third way of therapies like acceptance and commitment therapy. Like in development in CBT, we know that it is going through the three waves, that first wave of behavior therapy, then second wave of cognitive therapy, and third wave of acceptance and commitment therapy. Having more evidence base as well as integrating aspect of several successful interventions. Then adjuvant use of pharmacotherapy along with psychotherapy, although very old strategy, but it is trying in many novel ways, and the so that to help clients. Then it is also used along with brain stimulation to see that what kind of influences it have, and it shows promise that it shows that TMS or TDCS actually improves receptivity of client for some time. So integrating this might be useful, and clinical trials will inform that actually how and why to do this in conditions. Dr. Vishal also talked about psychedelics. A lot of important developments are happening, and for use of psychedelics in psychiatry, and also to use psychedelics in assistance to psychotherapy. And it is says that specific use of MDMA and psilocybin might improve the efficacy of psychotherapy significantly. And also technology is significantly affecting psychotherapy, like we are seeing advent of digital therapy, bot therapy, where trained robots are delivering psychotherapy, and certain trials have shown that this is as effective as human delivered psychotherapy and telepsychotherapy. Thank you very much. I know that I might have been spoken at a rocket speed at some parts, and I have not elaborated sufficiently on several aspects. But I'm open to question, and I hope that I might respond to them. Thank you.
Thank you, Dr. Adarsh. That was a very comprehensive presentation. I can see a lot of questions. I will take the questions and then maybe Dr. Sujata can give the final concluding remarks after the answers. I think we are already running short of time, so there are lots of questions, but I'll try to combine a few questions so it's easier. Dr. Adarsh, a lot of questions on the diagnostic classificatory systems. So let me try and see if I can club all of them. One of the main things that has been raised is why should you have two diagnostic systems in the first place? Why can't you just have one? Is one of the summary of one of the questions. The other thing is, why did they do away with all the subtypes when you use subtypes for prognostication? And there was a lot more detail available through subtypes. Why have they taken off subtypes, especially in the context of schizophrenia, for example? And one more thing on the diagnostic systems is if schizophrenia is so heterogeneous, as you mentioned, then why did we lump it together in ICD-11 again in the context of subcategories? So, yeah, this covers about 5-6 questions, Dr. Adarsh.
Sure. So this nosological developments is definitely a very science and evidence-based thing. So whatever is happening is backed by a lot of science. First, let me tell you. Having these two different classificatory systems is due to a lot of political and a lot of other reasons rather than purely scientific reasons. So American psychiatry plays a very different role in world, and they sort of have a lot of dominance as well as a lot of financial advantage of keeping DSM system alive. So that may be reasons for that. And ICD is a system of WHO. So this system is used all across the world, and they try to develop this system so that it can be used across different settings, from very developed country to very undeveloped resource constrained settings. So these are sort of ways I can very shortly tell about why there is existence of two different classificatory systems. Now the questions related to heterogeneity of schizophrenia and why clubbing it together. So I tell that this all psychiatric disorders are very heterogeneous, but this science has not reached to the level so that we can classify it into different subcategories. Our therapeutics has not reached to that level so that our identification of this subcategories can assist having different kind of treatments and different kind of interventions that are needed for the persons. This heterogeneity is at the level of genes. This heterogeneity is at the level of different biotypes at the receptor level and other levels. So, but clinically, these are clumped together because a lot of interventions are delivered currently as a group right now. The importance of nosology is manifold. It is not only researcher that are using nosological classification, because a lot of these questions are for importance for only researchers. A common clinician need to have a very short description of diagnosing a disorder and communicating it to a lot of other people, to the person, to the insurance agency, to the other colleagues who are not in your field. So the classificatory systems serve a lot of purposes other than simply diagnosing a case and prescribing. So that is why these are the way they are right now.
Thank you, Dr. Adarsh. He tried to simplify his best, a very complex question. There is an RDoc by INCEL, which is also coming through. I think then there will be more complaints that instead of one, we are having multiple systems. The other question is related to antipsychotics. There are 2-3 questions, related questions. Basically, all of them asking, why do we not have newer good antipsychotics which can work in treatment-resistant schizophrenia, for example? Clozapine has been an age-old drug. It is still the kind of a gold standard. why don't we have newer drugs? A lot of them are coming, but looks like they're just good on paper, but not so good when you start treating them, especially for treatment resistance. And can pharmacogenomics anyway be used to decide at this time which one respond to which antipsychotic? I think you covered the second part of the question, but briefly for these questions.
Yes. So, my friend, I completely agree with you first that we are not improving on terms of efficacy, as we have told. That if we talk in terms of efficacy, probably clozapine and haloperidol are still the most efficacious antipsychotic available to us right now. The science which has developed at this stage is primarily able to give that the age-old targets are still the most important targets of drug development. All other strategies that has been used in research have not could not be implemented very successfully. So that is why the drug development in psychosis has not progressed beyond this sort of dopamine hypothesis, if we call. Actually, that is not very correct term as of now. But just to summarize in very brief, that most of the antipsychotic revolve around that kind of strategy, and it is rather most of cosmetic changes in development of pharmacology which are happening right now, like newer drugs, which third generation drug which we are talking about, brexpiprazole or cariprazine or aripiprazole. These are more commonly called dopamine stabilizers. So they sort of try to stabilize dopamine, but they are effective in very minority of patients, and they have certain lesser risk of side effect, but they are not as efficacious as the earlier existing drug. So other targets for drug developments has not reached to the that scientific accuracy, so that we can develop drugs on that targets. That is why we are stuck currently the way we are.
One interesting question from Dr. Harshit is that the neurology colleagues of ours often regard psychiatric manifestations as supracortical in origin. Can the current day neurobiological understandings be substantially summarized to end this contradiction with the neurologists?
A lot of what I talked is, I hope that is answer to the question. This supracortical thing that what people call that mind is epiphenomena of brain. In that context, probably somebody might have said what they are saying, but let me tell you that every psychiatric symptomatology has their correlates at the level of neurons, at the level of circuits, at the level of cells, receptors, and molecules. So you can throw this information to them and can substantiate your claims that every psychiatric symptoms is having base on brain, and this is not something in mind as commonly people call.
I'll just take two more questions. There are lots more pouring in, but let me take just two more for the sake of time. One of the questions is on personalized medicine in psychiatry. At this time, do you think personalized medicine can be done with our clinical practice, considering that each patient is very unique and there are so many treatment modalities and the unpredictable nature of response to various treatment modalities?
Sure. So this also relates to the question which I forgot to answer related to pharmacogenetics. See, the only use of genetics as of now that has been able to come to clinical practice is pharmacogenetics. Hypothetically, if we talk about precision psychiatry or personalized psychiatry, then what we think in that term that someday in near future, a person will come to you having their whole genomic data in the cloud, which they will give you access. Then you access that data, then you match the existing treatment profiles to that particular data, calculate the polygenic risk score, then match it with the pharmacogenomic data and see that what are the medications that are likely to best fit, what are the medications that are likely to least fit for this particular person. And based on this information, you prescribe the person that you're likely to respond to aripiprazole 2.5 mg along with this theta burst brain stimulation of these many sessions. So this is what sort of personalized medicine we might think in future. What currently might happen is that the pharmacogenetics is the only practical solution that is happening right now, that you can map the gene of a person and match it with the available information related to drug and decide that which medication is likely to produce more side effect. If the person is having a particular variation of CYP chrome, so you know that this person is high metabolizer, so you need to give higher doses of this medication to have effect. Or this person is slow metabolizer, you need to start with 2.5 milligram of escitalopram rather than using 10 milligram of escitalopram straight. So these sort of small tweaking we are likely to do currently, and that is why these tests are very costly. That is why as a clinician, we are not able to use this test in our routine clinical practice, because a lot of time we do these modifications with our clinical experiences, and the accessibility and availability of these tests is not very wide as of now in the country.
Final question, you mentioned about psychedelics and the use in therapy. As of now, which conditions can psychedelics be used? What is the available evidence say?
Most data of psychedelic assisted therapy is coming from PTSD. That it says that the psilocybin assisted psychotherapies are able to reverse the effect of PTSD in shorter time, more effectively, and it sort of remit patients in shorter time, and thus remission maintained for longer period of time in comparison to traditional therapies that is being offered. However, these psychedelic assisted therapy trials are being conducted for other psychiatric conditions like depression, anxiety disorders.
Sure. Thank you, Dr. Adarsh. I think there are also prizes for questions. So I don't know, Anil can help us understand how the process is done, whether we do it now or later on, they will be informed. Thank you, Dr. Adarsh, for the wonderful presentation and also taking up so many questions patiently. Madam, over to you for your final remarks before we hand over to Dr. Anil.
Thank you, Dr. Vishal. I congratulate Dr. Adarsh for arranging this basket webinar with such varied content. What a colossal and stupendous task that you have performed, Dr. Adarsh.
Thank you.
Just admiring the amount of the hard work that you have put in. And I'm sure this webinar it has benefited everyone, and beautifully taken up the questions, as clarified, I would say, the confusions or the queries that have risen in the mind and stimulated the thinking. So that's really good. Thank you so much, and it's been wonderful. Over to Dr. Adarsh.
Yeah. It was very nice listening to you, Adarsh. Even I enjoyed it. It is a very difficult task to put the entire recent advances in 45 minutes. And you have stimulated a lot of questions. That itself speaks a lot about your abilities. The slides were very good. The flow of speech was very nice. And a lot of questions from the audience. And I will circulate the questions to 3 experts, and before the next webinar, and in the next webinar flyer, you will have the winners of the 3 questions who will receive the first 3 books free of cost as prizes, the recent advances in psychiatry book from Indian Psychiatric Society. So I hope the participants have enjoyed like us, and it has stimulated or kindled the thought process to look more on recent advances and develop more and more interest in psychiatry. Any last comments for incoming President Dr. Vinay Kumar sir?
Sir, you are mute. Sir, kindly unmute you.
Nothing to be added. It was a Gavaskar century. That's all. Very quiet and scoring ball after ball after ball. And so thank you, Adarsh, for beginning the whole journey in such a smart fashion. I think Anil, our sponsors will be giving IPS publications to 5 best questions.
Okay, that's
So
good.
5 best questions. No first, second, third, just 5 best
My
questions.
job easier.
It becomes easier for everybody. And if attendance is more, then they are ready to increase it up to 10. So 10 best questions like that. So,
That's nice.
but the thing is, they have to write along with questions. They have to write their address or email ID, at least something.
I have noted down all the details and it is with me. We will put the winners in the next flyer. And thank you for the participation. And I should immensely thank Dr. Adarsh, Dr. Sujata Sethi, Dr. Vishal Indla, and Dr. Vinay Kumar, Dr. Murugesh Vaishnav in his absence, and all the publication committee members for their wholehearted support and making this program a grand success. I hope the program has, the intent has reached the audience and it has kindled some interest in recent advances, and looking forward to your participation in future too. Thank you one and all, and have a great dinner and a great evening. Good night.
Thank you very much. Good evening, everyone.
Thank you.
अब recording off करो यार.